Yeah. We're live. Does that mean we get to start?
Yes.
Mitzi, you ready to
Let's
rock
do
and
it.
roll?
Ready to rock.
Howdy do. Let's fire it up, guys. If our moderators would kick us off, we can do this. Oh, they're not doing anything, Mitzi. Maybe they want us to start somehow. I don't see any introductory slides. I guess we could make up our own introduction. Should we just do that?
Yeah, I think so. So I think we'll just introduce ourselves and get the party started.
All right. Well, I'll just jump in really quick. My name is Aaron Boster. As always, thank you for learning about MS with me. I'm the founder and president of the Boster Center for MS. I am super thrilled to be here tonight with a friend in MS powerhouse. Dr. Williams, would you introduce yourself?
Absolutely. Hi, everyone. Thank you so much for taking out your time this evening. We consider it very valuable, and we will definitely not waste it. I am Mitzi Joi Williams. I am a neurologist, fellowship trained MS specialist, and I am the medical director and founder of the Joy Life Wellness MS Center in Atlanta, Georgia.
Hotlanta.
Hotlanta.
Today we are going to have some fun. Now, I don't see the introductory slide. And so if instead I just jump into the learning objectives, maybe we'll have some of those introductions in a little bit. Today, we have an action-packed 45 minutes for you. And the learning objectives are as follows. Our goal is to help recognize the importance of early diagnosis and thereby early treatment in reducing disability progression amongst patients with MS. Number two, we're going to talk about the concepts of personalized treatment selection when you're starting, switching, or stopping pharmacologic treatment, considering the elements of efficacy, safety, and of course, patient preference. Number three, we intend to evaluate the latest and greatest data on efficacy, safety, dosing administration of currently approved DMTs to develop an optimal individualized treatment strategy to help people impacted by MS. I'm then looking forward to evaluating potential benefits of some emerging therapies, things that are coming down the pipeline quickly with intentions to delay disability, slow disease progression, and improve long-term outcomes in MS. Lastly, we intend to identify up-to-date recommendations for patients with MS during this COVID-19 era, including registries and treatment considerations. So strap in and let's get started. Now, here in front of you, you see Stephen Kriegers' Leaky pool model or topographical model of MS. This is a favorite of mine. I'm a student of Stephen's, and I actually use this literally in almost every clinic visit. Let me break it down for you if you're not familiar. This is a model to help people understand MS. And what you're looking at is the cross-section of a swimming pool. The surface of the water is the clinical threshold. Things above the surface you're aware of. Things below the surface I can see on the MRI, but you're not aware of them. Now, the amount of water in the pool represents a very important concept called the functional reserve. The functional reserve is your nervous system's ability to withstand an insult. Now, I don't mean like an insult like you're ugly. I mean an insult like you have a fever or you have an infection, God forbid, or even during a menstrual cycle or during a very serious psychosocial stressor that can tax your nervous system. And you'll notice that in the deep end of the pool, where I would be definitely underwater, I'm a pretty short guy, that got the highest functional reserve on the deep end. Now, if you go to the shallow end of the pool, where I'd probably hang out, that's got the smallest functional reserve. Now, the floor of Stephen's swimming pool is a representation of the nervous system. And in the area with the least amount of functional reserve, the area that's at the highest risk for damage, the area that is the least able to withstand an insult, you see that on the far left in that salmon color, this spinal cord and optic nerves. In the middle, where you have a middle of the road amount of water, this represents the brain stem, the base of the brain. And on the far right, where you have functional reserve and then more functional reserve, this is the cerebral hemispheres, the lobes. Now, in Stephen's model, when you have an attack, we demonstrate the attack by putting a stalagmite. You see that white pillar pushing up from the surface of from the bottom of the pool and cresting the surface of the water. It's above the clinical threshold, therefore you are aware of it. Now, if you look at some of those stalagmites, the white ones that are underneath the water, those would be MS activity on the MRI, but nothing clinical. It would be asymptomatic new lesions. And so, as you can see, we can represent the disease activity of attacks and MRIs on this model. Now, it's called the leaking pool model of MS, and I want to use it to make a very important point. Over years, decades, the water level drops. And so if you have a stalagmite that's below the water level, you're not aware of it. But as you age and as the water level drops, it uncovers area of damage. This is the underpinnings of progression. And I'll share with you, this tool allows us to understand MS much better and to understand the impact of disease-modifying therapy. Next slide, please. So we're going to shift gears now, talking about how we navigate the management of a complex immunologic condition like MS during a global viral pandemic. What you see here is the summary of rapidly collected information from some outstanding organizations, to include the National MS Society and the MS International Federation. And this is the collection of a lot of work trying to give us insights into the current evidence of how DMTs impact COVID outcomes. And I'm specifically talking about, if you contract COVID, do you have a more intense infection potentially because of a given drug? Now, if you look from left to right with me, people with MS who are taking injections with glutathione acetate products, with interferon beta products, or taking the pill teriflunomide, these medicines are not considered to increase risk of severity of COVID-19. If you look down a level at the fumaric esters, at the S1P receptors, and at natalizumab, again, these drugs are not considered to increase risk of severity of COVID-19. In counterpoint, some of the anti-CD20s, particularly off-label rituximab, has in fact been associated with concerns of possible worsening of COVID-19. If you look at the far bottom, it's actually outdated because we now have some newer information, but suffice it to say that during certain periods of time after treatment with alemtuzumab or cladribine, there can be a dip in your white count, and that could increase the risk of a more severe COVID, although we would not expect that out farther when you've reconstituted your cells. On this next slide, we summarize, again, work from the National MS Society suggesting that if you have MS and you're on a DMT, you're on it for a good reason, and we don't want you to stop, because long after the global viral pandemic's over, you'll still have MS, and we don't want to allow you to accrue disability in the interim. Now, of course, if you have MS and you're on a DMT, or not for that matter, and you develop symptoms of COVID and you test positive for COVID, it's critically important that you call your MS neurologist and have a discussion about what to do as next steps. Now, the playing field is different if we're talking about starting a new disease-modifying therapy, because that gives us a window to intervene with vaccines, and it gives us an opportunity to talk about risk before we get rocking and rolling. Should patients with MS get a COVID-19 mRNA vaccine? The answer is yes. So the vast majority of people impacted MS would be very well served to get a COVID-19 vaccine. I, as an MS specialist here in Columbus, Ohio, have absolutely implored my patients and their families to do so. And here's some data about specifics. If you have progressive disease, if you are over the age of 50, if you have accrued a degree of neurological disability, if you have comorbid conditions, to include things like diabetes, high blood pressure, obesity, heart disease, lung disease, if you are pregnant, if you are Hispanic or African American, we recommend that you get a COVID-19 vaccine. These are very, very important because these are all independent risk factors for a more severe disease. I also implore family members of people impacted by MS to help their family by getting themselves vaccinated. I can't stress this point enough. Now, this slide is very important, not talking about the impact of disease-modifying therapy on COVID infection, but talking about the impact of disease-modifying therapy on COVID vaccination. And what we've learned is really, really important. First of all, if you're taking an interferon beta product, or if you're taking a fumaric ester, then those drugs do not appear to impact the success of receiving a COVID vaccine. So if you're on those drugs, get a COVID vaccine, all is right in the world. Similarly, if you're taking glutathione acetate or teriflunomide, or one of the S1P1 receptors, or natalizumab, this slide says that there's varying degrees. And actually, since this slide came out, we have some new information. So what we know is gluteramine acetate, teriflunomide, and natalizumab do not infect COVID vaccine response. Unfortunately, it looks like the S1P receptors may. Cladribine, interestingly, does not appear to impact COVID vaccine response. And alemtuzumab really depends on the timing of the therapy. So it would impact it if your counts are still below 500, less so after you've reconstituted. Interestingly, the anti-CD20s seem to block the humoral response of the vaccine, but not the T-cell response. So in summary, if you're taking an S1P1 receptor or an anti-CD20, there's a concern that you won't mount a full vaccine response. Most of the other medicines are okay. Very important slide. Now here we're talking about treatment for people with MS who contract COVID-19. Remdesivir is a medicine which was recently studied and suggested for both adults and children for treatment of COVID who require hospitalization. And that's something that wasn't available even just a few months back. Other treatments given by the EU and the FDA are still under investigation. Many of the patients in our neck of the woods who have contracted COVID have received monoclonal antibodies. Mitzi, I don't know about down in Atlanta, but we've been calling that third one Bam Bam because I can't pronounce that long word. But these monoclonal antibodies, I can say anecdotally, certainly have seemed to help our patients get better faster. And there's definitely accumulating data supporting the benefit of these. Now, for patients with MS who become infected with COVID-19 and they meet the criteria for pharmacologic treatment, we're going to have to look at the individual factors, the individual drugs they're taking, and then together make the best decision. I can tell you 9 times out of 10, I'm asking them to get the monoclonal, and it seems to be helping. I'm going to turn it over to Dr.
Awesome. All right. So I'm going to talk a little bit about the current therapeutic landscape for MS. All right. So, when we think about the treatment of MS, it really has been revolutionized even within the past decade or so. So, we've come a long way. The three main types of medications that we have to treat MS are injectables, oral therapies, and then our monoclonal antibodies. And it's a little bit of a misnomer because one of our monoclonal antibodies is an injectable. But typically, when we think about injectable medicines, we think about our platform therapy. So, those are our gluteramine acetate, as well as our interferons, which are some of the first medicines approved for MS. When we talk about our oral therapies, we really have a wide variety of the different types of mechanism of action of these medications. So we've got cladribine, which is in its own class. We've got the fumarates, which includes dimethyl fumarate and diroxyl fumarate, as well as monomethyl fumarate. We have got several S1P receptor modulators, as well as teriflunomide. And then for our monoclonal antibodies, we have our B cell or anti-CD20 B cell therapies, ocrelizumab and ofatumumab, and then we have alemtuzumab and natalizumab. Next slide. So I'm going to go through a little bit of data, some of which you may be familiar with, but just kind of hitting some of the highlights of some of the data concerning the effectiveness of these therapies. So this was, data from the pivotal trial for cladribine called Clarity. And basically in this trial, there were 2 doses of cladribine, but the one that was approved was a 3.5 milligram per kilogram dose. And we're looking at 3-month confirmed disability progression. And this was the 2 doses of cladribine versus placebo. So even though it is a drug that was approved more recently, the original studies were done back in the early 2000s when many of our trials were versus placebo, versus our newer trials are almost all versus active comparators. And so we can see that there was a significant decrease in the risk of confirmed disability progression for those who were on cladribine versus those who were on placebo. Now we'll switch gears and talk a little bit about siponimod, one of the S1P receptor modulators. So this was looking at progression and secondary progressive MS. It led to one of the new designations by the FDA of active secondary progressive MS as a class of MS that's approved for most of our therapies now. And we can see here in the EXPAND trial, looking at 3-month confirmed disability progression as well as 6-month confirmed disability progression, that there was an improvement or reduced risk for those who were on siponimod versus those who were on placebo. Now, moving on to diroxyl fumarate, which is very similar to dimethyl fumarate. These are the Evolve MS1 and Evolve MS2 studies. And so essentially, Evolve MS1, the results were looking at annualized relapse rate to show similar efficacy between dimethyl fumarate and diroxyl fumarate in terms of the decrease in annualized relapse rate. And those results are very similar between the two therapies. And then also in Evolve MS2, was really focused. Here's some of the results that were really focused on GI tolerability, because that's one of the main side effects of dimethyl fumarate, is that there are GI issues. And we can see that those were decreased in those who were on diroxyl fumarate versus those who were on dimethyl fumarate. Now, talking a little bit about ozanimod, the two pivotal trials for ozanimod were Sunbeam and Radiance. And looking here at the primary endpoint, we can see that there was a significant reduction in annualized relapse rate versus interferon beta 1A. And then some of the secondary endpoints, there also was some interesting data looking at new or enlarging T2 lesions. Those were significantly reduced. Gadolinium enhancing lesions were significantly reduced at 12 months, but there were no significant differences noted in the 3 and 6 month confirmed disability progression in either study. Ocrelizumab, this is data looking primarily at primary progressive MS. And again, when we look at 12-week confirmed disability progression and 24-week confirmed disability progression, we can see that there's a significant reduction compared to placebo. And then ofatumumab, which is one of our newest monoclonal antibodies. And again, even though it is a monoclonal, it is also an injectable therapy that's given once a month. We can see that there certainly were significant results in terms of annualized relapse rate compared to teriflunomide. And then also when we look at some of these other outcome measures in terms of gadolinium enhancing lesions, newer enlarging T2 lesions, there were also significant results, as well as serum NFL, which is a very interesting biomarker that Aaron and I will probably get a chance to chat about a little bit later on in the discussion. And then finally, looking at ponesimod, which is the newest S1P receptor modulator, which also was compared to teriflunomide, we can see there were significant results in terms of annualized relapse rate, and also combined unique active lesions. On MRI, there was significantly reduced risk for having more of those, as well as brain volume loss. So again, we're looking at lots of different measures in some of our newer studies. Many of them are with active comparators. We are now comparing oral therapies to some of our newer therapies. And so there's a lot of promise in the treatment landscape at this time. So I will hand it back over to Aaron to talk a little bit about what is on the horizon.
Mitzi, thank you for that. That was fantastic. A great summary. I'm now going to walk us through some of what's coming down the pipeline. I'll be talking about a fully humanized monoclonal antibody, ublituximab, a tyrosine kinase inhibitor that I struggle to pronounce, masitinib, and then a couple Bertine tyrosine kinase inhibitors, evobrutinib, tolobrutinib, and fenebrutinib. Let's jump in. Here we're looking at ublituximab in both the Ultimate 1 and Ultimate 2 trial, where they were pitted, this monoclonal was pitted against teriflunomide. And what you see is, when looking at the MRI measures in this phase 2 trial, we saw some really cool things. We saw that the MRI outcomes were very, very in favor of the monoclonal ublituximab, with very significant improvements to contrast and to T2 enlarged lesions as compared to the comparator. Now, interestingly, it did not hit the mark with confirmed disability progression, either at 12 or 24 weeks. And it kind of highlights the fact that teriflunomide is a pretty good drug at confirmed disability progression. When we looked at confirmed disability improvement, however, arguably the three most beautiful letters, CDI, in our field, we saw that ublituximab outperformed teriflunomide at both the 12 and the 24 mark. Lastly, when considering NETA, the target that I treat towards, no evidence of disease activity, we see that, again, ublituximab outperformed the comparator quite handsomely. We turn our attention to this tyrosine kinase inhibitor, masitinib. This small molecule was tested in a fascinating trial. I love this data, where we studied people with MS, but with either PPMS or non-active SPMS. So we've really selected a population that doesn't have attacks. And this is arguably the hardest population for us to see benefit in, but we did. Now, what's really interesting is there was a kind of a U-shaped dose curve where a medium dose, 4.5 mg per kg, against placebo rocked the Casbah. And that's what you see in that little table there. Looking at change in EDSS, there was a statistically significant decrease in EDSS change compared to placebo. When you look at risk of progression, and when you look at risk of first progression, again, masitinib is performing better than placebo. It didn't hit the mark with 12-week confirmed disease worsening, but I do want to share with you that this is a really big deal. It's been so hard to find molecules that impact this disease state. I was very excited by this. What's really interesting to me is when you go up the dose, more is not better. In fact, the higher dose was not seen to be better than placebo. There were plenty of side effects, including a lot of GI stuff like diarrhea, nausea, rash, and there were also some hematologic changes. So this is one to look out for, and more to come with this exciting tyrosine kinase inhibitor. This data now turns to one of the BTK inhibitors, evobrutinib, which is actually leading the charge in completing phase 3. This is the drug that has completed its enrollment and is now charging forward with the phase 3 trial. Here we see the phase 2 data. And at the top, you see that placebo, and then you see different doses of evobrutinib, and then a comparator dimethyl fumarate. And what we see is, particularly with the 75 mg dose once a day or twice a day, that there is a very striking drop in new spots. And I will share that 75 BID dose is the dose that went forward to the phase 3. If you look at the bottom of the graph, instead of looking at new spots, we're looking at relapse rate, and we make the exact same comments. Compared to placebo with an annualized relapse rate of almost 0.4, we drop that down by a fourth down to 0.11, suggesting one attack every 10 years. Very, very impressive data for this small molecule. Now here we turn our attention to another BTK inhibitor, telebrutinib. This drug is rather fascinating in that it has CNS penetrance, which I think is very important. And in the phase 2, it really did a very bang-up job of demonstrating efficacy. So we see in this relapsing phase 2 trial that as compared to placebo, it was remarkable in improving new contrast-enhancing lesions. And similarly, it was equally as remarkable, if not maybe a touch better, cleaning up new T2 lesions. Most importantly, I think that there were no safety signals in this phase 2B, which has allowed us to enter into phase 3. And telebrutinib is actively enrolling for SPMS, PPMS, and RMS as we speak. Let me kick it back to Dr. Williams to talk a little bit about diagnosis and risk assessment.
Absolutely. Thank you for that amazing summary, Dr. Boster. And, I finally did get that pronunciation right, masitinib. So somehow I was missing that I, and I was calling it mastinib. So thank you for that. I learned something tonight. All right. So let's talk about diagnosis and risk assessment, and then we'll have a little bit of discussion. So essentially, this is just kind of listing the 2017 revised McDonald criteria for MS. And of course, the goals with many of the revisions of our criteria are to try to diagnose MS and treat as early as possible. So we can see that some things haven't changed. If you've had 2 clinical attacks, plus objective evidence of clinical lesions, you got MS. If you have 2 attacks in one area of clear evidence of a previous lesion, as well as an attack involving a lesion in a distinct location, you got MS. But some of the things that, have been adjusted a little bit are the use of oligoclonal bands as a form of dissemination in time for that second to last line, and then also using oligoclonal bands as that dissemination in time, as well as dissemination in space with additional clinical attacks and different that are seen on MRI. Those are some of the things that help us to diagnose MS a little bit earlier and to get people on treatment and on target a little earlier. In terms of diagnosis with primary progressive MS, we can see here with the revised criteria, a person has to have 1 year of disability progression, either retrospectively and independent of clinical relapse. And then we can see they have to have 2 of the following that are listed below. Greater than 1 T2 hyperintense lesions in multiple areas, greater than 2 hyperintense lesions in the spinal cord, or the presence of oligoclonal bands. So oligoclonal bands have reemerged with the revised criteria. Now, let's get into a case, and we're going to follow this case through in the next couple of sections. So let's talk about Natasha. She's a 24-year-old Caucasian or white woman, newly diagnosed with relapsing MS. And her initial attack was multifocal. So she had fatigue, she had optic neuritis, and she had paresthesias in her hands and feet. She fortunately did recover fully from that attack, but on exam, we can see difficulty with proprioception, some sensory ataxia, as well as gait disturbance. And on MRI, she's got 4 T2 lesions, none are GAD enhancing, no cord lesions, and she's got normal labs and a negative JC virus. So let's bring Erin back up and let's talk a little bit about how we would treat this patient. So, Dr. Boster, what are your thoughts about any further testing you would do? Like, would you get CSF on this patient, or is it pretty clear, straightforward that her diagnosis is MS?
In Europe, I think the answer would be a definitive yes. In my practice, this is a young Caucasian woman who presents with a classic presentation with classic findings on the MRI. I'm probably not going to feel the need to tap her. What are your thoughts? Would you do
Yeah.
an on her?
Yeah, so I would agree. So if there's anything that seems a little bit off, I still am in favor of getting lumbar punctures.
Mhm.
But if, the lesions are very classic and her syndrome is very classic, she's obviously got multiple areas that are affected on her exam, I probably also would not get oligoclonal bands on this patient. And is there any other testing that you would do? Are you using serum NFL in your regular practice, or
I
how are
would
your
love
thoughts?
to. I can't get a hold of it. So
Right.
if you have a backdoor number where I can order a neurofilament light and serum, please text me later. Um,
Absolutely.
I think that this would be a perfect case where you and I would like to know her neurofilament light. But probably aside from getting a battery of labs to look at the playing field and the immune status and infection risk, I'm probably not doing much else.
Yeah.
I probably wouldn't, for example, get evoked potentials in this
Right.
patient.
Mhm.
An OCT might be nice to look at as a baseline. Doing the MRI so that I could look at brain volume as a baseline. These are things that I might want to do. What's your take on a further workup for this gal?
Absolutely. I think the workup is pretty much complete other than
Mhm.
labs. I always, with a new diagnosis, look for other rheumatologic or autoimmune
Amen.
markers, right? So other than that, I think that the workup is pretty much done.
Yep.
Now, in terms of prognosis, what are your thoughts about her prognosis? Just based on she's got 4 brain lesions, multifocal onset, no cord lesions. What are your thoughts about her prognosis?
I feel like there's a lot of things in her favor, not everything. She's white, she's young,
Mhm.
she's a woman. Those are 3 demographic features in her favor. Her presentation is not in her favor. A multifocal presentation statistically looks poor as an outcome as compared to just having one thing.
Right.
I love the fact that she fully recovered. I think that's a good prognostic factor.
Agreed.
And the fact that she doesn't have any cord lesions, I think is good. Also, when
Absolutely.
you look at the number of lesions, if we look at the 20-year Queen Square papers, we would suggest that 4 lesions is on the lower side and would be a better outcome than saying having more than 10. So really the only thing that's kind of got myself a little bit concerned is that multifocal presentation.
Yeah, I would agree. That overall, there are many things that are in her favor, but the multifocal presentation is definitely concerning. And then, of course, that risk factor might change or that prognosis might change if, for instance, she did have multifocal cord lesions,
Amen.
or, if she had only partially recovered from her attack. So, those are all things that we're thinking about as we are, trying to predict how patients are going to do and as we're trying to choose therapy.
100%.
Thank you. Next slide. Okay, so when we think about poor prognostic factors, some of the things, Dr. Boster and I already mentioned. So, poor demographic factors are men tend to do worse than women if they're older than 40 years of age at onset. And then certain ethnic groups, such as African Americans or Asian, tend to do worse. Also, if they're oligoclonal bands, as well as multifocal lesions on MRI. So, a hot looking MRI certainly would be very concerning. And then, in terms of disease characteristics, if they're motor symptoms from onset, incomplete recovery, frequent attacks, etc. These are things that will make you concerned that someone may have a poor prognosis. So, individualizing treatment. So when we think about Natasha, so we talked about some things in terms of we want to think about the natural history of MS, right? We want to think about and talk about the goals of treatment with her. What are her life goals? Is she in school? Is she, a busy mom of 4? Is she planning on childbearing anytime soon? In terms of no evidence of disease activity, which Aaron mentioned as, his target to treat, for some neurologists, is this really our goal, right? Do we think this is feasible? And I think it's very important to address that. What are we looking for, or what does success look like? We certainly would want to review the different options that we think would be good for her. I think we've gotten away from sending everybody home with 10 pamphlets. We certainly need to narrow down those options and offer some recommendations. And then think about, is she a candidate for high efficacy therapy? Think about her risk tolerance, her preference, and then that shared decision making process is extremely important. Also, we want to think about her concerns that were treatment related. What about infusions? Would she be able to do an infusion? Is there any concern about the frequency of monitoring for certain therapies? Also, we want to think about the impact on her work and lifestyle, as well as the impact on her family and care partners. All right. So let's talk a little bit about discussing picking a DMT. So, what factors would weigh pretty heavily in your selection, Dr. Boster, for picking a DMT for Natasha?
I want to put Natasha on the single most effective drug she's comfortable with.
Yep.
I have to be honest, and I may be a pariah in saying this, but even though she doesn't have that many risk factors, I don't think that it's my job to be paternal and to tell her she can or can't have something. I honestly am gonna listen very carefully to her goals, and I'm gonna try to help her achieve those goals. And whether or not my view is popular, I'm gonna put her on the most effective drug that she's currently comfortable taking. Now, as you look around the graph that's on the screen right now, all of these are terribly, terribly relevant. But to me, in my soul, where I start my thought process is with efficacy, and that's kind of what leads my discussion. And then we have to see where everything else falls into place. Now, I know that my style is a little bit different, and I would kind of love to hear from your standpoint, which things really speak to you when you're starting to engage with this patient.
Yeah, so absolutely. I would agree. Efficacy is at the top of the chain for me. So, I'm very much an advocate of treating people with high efficacy therapy. If I want to hit it hard, as hard
Amen.
as I can, because the issue becomes, if someone has very aggressive disease, it's very easy for us to say, give them high efficacy therapy. But if someone doesn't, we kind of want them to stay that way, right? So when I think about treatment options, I think about, if I could freeze you in time and keep you like this,
Amen.
what can I give you that would keep you like this? And so, I agree with you wholeheartedly. High efficacy, as much as they feel comfortable with. So, I think that's extremely important. And of course, we have to talk to the patient, see what their goals are, make sure that we are offering, some options, and then listening to them in terms of risk tolerance. But I find that many people are very tolerant of risk if they feel like it will preserve their function and
Yep,
help them to operate
100%.
in their daily lives. Yeah. All right. So let's move on to the next slide. All right, so when we think about patient-centered treatment selection, certainly we definitely want to talk about efficacy, but there are other factors to consider as well. We want to talk about safety and potential side effects, dosing, things that will be convenient for the patient. Certainly, the medication that they will take is the most effective one, right? It's not going to be very effective if they can't take it or be compliant with it. We also want to take into account what type of monitoring is needed. Would that be cumbersome on them and their lifestyle? Cost, if there's a cost associated with it, and especially maybe more of the case for some of our infusion therapies, because fortunately there often is a lot of support to help underwrite the cost of medication. But if there are other administrative costs associated, sometimes we can't necessarily cover all of those. So all of this goes into our thinking and thought process when we're talking about individualized treatment. Next slide. And so relative efficacy for our DMTs, this is kind of a just generalization, right? But so, I usually tell my patients, we have shots, we have pills, we have IVs, right? And there are exceptions to those. But generally, as we go from our platform therapies to our monoclonals, we're going from less efficacious to more efficacious. So, and this is an interesting study that looks at early high efficacy treatment and shows that it's associated with reduced MS disability, right? So, this is one of the big questions, and there are multiple clinical trials going on around the country that are trying to answer this question. What is the difference between escalation therapy versus high efficacy therapy early? And are we really making a difference when we start with high efficacy therapy early? And this study would suggest that we are making a difference. So, it looks at patients who started high efficacy, 4 to 6 years after the diagnosis of MS, and we see that they never caught up that they certainly continue to have a separation in terms of their disability level out to 8 years versus those who started high efficacy within the first 2 years of diagnosis. And then also thinking about safety and tolerability. I'm not going to read through all of these side effects. I know that many of us are familiar with these, but certainly we have to think about side effects with our injectables or things like flu-like symptoms and injection site reactions, as well as, for the interferon, sometimes headache, as well as liver function increases. For some of our other drugs, we have issues like lymphopenia. With our fumarates, there's GI issues. With our S1P modulators, there can be, cardiac interactions with medications, etc. And then with teriflunomide, hair thinning sometimes can be a difficult one, especially for the ladies. And then also headache and abdominal discomfort can be a side effect, as well as increased LFTs. And then in terms of our monoclonals, each of these are different. Certainly things that we're concerned about are infections, right, such as PML, as well as upper respiratory infection and infusion reactions, as well as injection reactions with some of these therapies. All right. And then the other thing to keep in mind is monitoring. What type of testing, what type of workup do we have to do prior to starting a drug? We can see, at least from this graphic, that the S1P modulators kind of have the most workup on the front end before people can start therapy versus some of our other injectables or cladribine and the fumarates. And then, of course, with our monoclonal antibodies, there are different types of, monitoring that must be done. But generally, we're looking at a CBC because many of them are depleters. We are also looking at immunoglobulins now for our anti-CD20 therapies and looking to see if we have to replace immunoglobulin, and then screening for things like hepatitis B, HIV, etc. So Natasha's second follow-up visit, she decides to start ocrelizumab, and then she has an attack in the first year, or a new lesion. And so, what are we going to do with her? So, what do you think, Dr. Boster? What are we
So
going to do with Natasha?
there's a lot to discuss. I think if you look at the data, there's really one of two ways to go. I think either A, you cut bait and escalate, or B, you give it a warning and say that was your one mulligan, and if anything else happens, we need to escalate. I'm citing in the second example the Rio criteria.
Right.
I think he gets a little bit into style. I also need to hear from her the litmus test of life. If she is killing it, her energy is on point, her game is on point, she's living her best life and had breakthrough once, we might be more inclined to keep on keeping on with a zero tolerance policy. But
Right.
if she struggled with this drug, Mitzi, if she's dealing with the crap gap and just not loving life, that might drive me to move on quickly. How would you address this? Because this is not uncommon. What
Yeah.
would you do?
Absolutely. So, in the first year, depends on when it occurs, right? So, most of our medicines, we say it takes a little while to get in the system. So, I do give people definitely a bit of leeway between their first round and their second round. So,
Mhm.
between their first two halves and their first, their second, their full round of therapy. And so, sometimes we know that during that period, there's a period where the medicine is really becoming active. So,
Mhm.
I have had some folks who've had relapses, and we said, okay, kind of similar to what you said, one time deal. If it happens again, we're going to, call it
You
quits.
know,
But if they are otherwise doing well, their MRIs are stable, that would be a person I would be more inclined to say, let's, keep pushing forward versus let's come off the therapy.
I agree with you completely. I imagine, someone brings your daughter home late once, you're going to sit them down and have a discussion.
Yeah.
They bring her home late twice,
Yeah.
no longer.
Yeah. Yeah. My husband's not going to have a discussion. Not after the first time.
He's going to be
He's
he's going to
going
be a
down.
rapid
He's going
escalator.
down.
Rapid escalator. That's
There'll be
exactly right.
rapid escalation.
I love that.
Okay. All right. Great discussion. Okay. Let's move on to the next slide. All right. So when we're thinking about monitoring for progression, there's certain things that we're looking at. Some of these we mentioned. We certainly look at EDSS or their disability. We're looking more and more at patient-reported outcomes. Certainly looking at their MRI. Right. In MS, I always talk about how most of the time in medicine we say you treat people, you don't treat tests, but we do to an extent in MS treat these MRIs, because if these MRIs are getting worse, even if patients are doing well, it certainly gives us pause to talk about their treatment plan. And then in terms of laboratory tests, these two that are listed here, NFL and GFAP, are really more experimental. I haven't been using those much in clinical practice. I'd love to see, Aaron's opinion about that. But certainly things that hopefully in the future we'll be able to look at to kind of monitor how people are doing and monitor relapses over time. So, this is a slide looking at MS progression independent of relapse activity. And so basically, what they found was that underlying progression was not dependent always upon overt relapse activity. And Ocrevus obviously was superior to interferon 1A in preventing relapses, relapse associated worsening, as well as progression independent of relapse activity. All right, so thinking it back to Natasha, we're a couple of years later. She's had no acute attacks, but she still has some symptoms, some fatigue, difficulty sleeping, and bladder issues. She's taken a new position at work, and that requires less travel time and commitment. And so the question is she passing the litmus test of life? All right, so what do you think, Aaron?
I like the real world aspect of this case. It's not a slam dunk where someone has a devastating attack and every one of their chickens says, get off. But you have a mom who's trying to live her best life and work, and she's having some problems. And so I think at bare minimum, we need to have a very legitimate conversation. This is one where I want the patient to come into the office. I want to sit down and I want to have a real long talk.
Right.
Because it's not clear. I would start to look for, am I finding evidence on my testing of slippage? Are you walking slower? Are you moving pegs slower? What's going on with the cog functioning?
Right.
This is one where my cackles are going to be raised, and I'm going to be watching this young lady very, very carefully for fear that we're slipping a little bit. What do you think when you read this case?
Absolutely. And the thing about it is sometimes hindsight is 2020. We're coming in for those regular visits or we're doing televisits and it seems like everything's okay. But when you get a little further down the line, it's like, actually, this has gotten worse. This has gotten worse and this has gotten worse. So maybe we need to reevaluate. So, I think that's why treatment is always a continuous discussion at every visit. Are we still doing the right thing? Do we need to switch gears and do something else? So I agree.
We don't marry therapies. We date therapies.
Absolutely.
I'll tell you what, if he misbehaves, we take him out of your phone. We take him off Facebook.
That's right.
We're going through some things and we'll call him and then we'll never call him. You know what I'm saying?
Absolutely. Absolutely. I always say the plan is not written in stone. So if the plan is not working, we switch on and move to something else.
Amen. Completely agree.
Right. Perfect. All right. So let's keep moving. I think we're getting close to the end. So I will hand it back to you.
Thank you so much
to help us close out.
All right, let's do it up. This has been a powerhouse 3/4 of an hour. And in quick summary, early treatment approaches and the advent of more effective, literally better tolerated DMTs have increased the potential for improved symptom control and maybe more importantly, reduction of disease progression in this disease. The expansion of treatment options has made it possible to provide patients with therapies that are highly tailored based on their efficacy, safety, and those patient preferences. While positioning of highly effective therapies is an evolving discussion, recent and emerging data that I think Dr. Williams and I both endorse indicate that the earliest use of can have a significant beneficial impact on the long-term outcome of our patients, something which is very, very important. And lastly, a new but important part of MS management involves guiding patients as they navigate current COVID-19 pandemic. This is absolutely part of our job now. And in general, patients should be provided with education on their individual risk to become infected and counseled as appropriate to get vaccinated, continue using their DMT as prescribed, and seek treatment if they contract the infection. And now there's a silent pause while I wait for the sponsors to change the slide.
Absolutely.
I think this may take us to the very end of our 45 minutes together.
Yeah.
I did want to ask people to make sure that you claim your CME credit because you just listened to us and upped your game, and I'm grateful for that. And so if you can complete the post-test evaluation, the form will be provided for you, then you can collect your CME, and we know how important that is. I also want to recommend we don't forget to check out the tutorial on individualized patient-centered DMT treatment that Barry Singer and I put out yesterday, so you guys can check that out on the Twitters. And lastly, check out the Twitter chat on risk assessment that's going to be live on December 8th. So stay tuned.